Amy is a nurse in South Carolina. She's been working in public health for 26 years and in TB control activities in the last 17 years. And she's currently the tuberculosis section director for the Carolina Department of Public Health. And she's going to be telling us about an outbreak they had a couple years ago that sounds like it was quite significant and interesting. So I appreciate you sharing your experience with Amy. We like to make this interactive, so um, please, Amy, would you let us know if you want us to ask questions in the middle or at the end, and I'll let you take it over. Thanks, Amy.
Thank you so much for the introduction. I'm going to do a share screen. Give me 1 second. If I can get confirmation from the panelists that y'all can see.
Yep, looks good.
Perfect. Thank y'all so much for allowing me to join today. So I am Amy Painter. I'm the State Director of TB for South Carolina. I've been in TB services since 2018, and prior to this role, been in TB services since 2008. Came to this role in 2018, but prior to that, I was a frontline nurse providing direct patient care, and then became a manager for a 12-county public health region here in South Carolina. And before I get started, I think it's very important to talk about how South Carolina works as a public health entity, because it kind of became the critical became critical in our success in our TB outbreak in a long-term care setting. So we are a centralized public health entity, which means that the state office where I work provides oversight to all of our South Carolina counties, and all counties function the same within our state. Our state is broken down into 4 regions, and each region has 11 to 12 counties. And each region has their very own TB team, which consists of a nurse manager, 2 nurse team leads, 4 to 6 frontline nurses, and 2 admin who are cross-trained with phlebotomy duties. So let's get started and talk about the outbreak. I have no financial interest or relationships to disclose. And by the end of this, I want to make sure you're able to describe the standard TB contact investigation protocols in the congregate settings to advance case identification and reduce secondary exposure risk amongst high-risk populations. And I also want you to be able to identify strategies and resources to support development of an outbreak response plan for long-term care facilities to minimize deployment lag times during active exposures. I do want to make a disclaimer before we get started that the contact investigations that I share here are only from July of 2022 until early December 2022, and they're related to the index patient only. These results are not all inclusive of the work performed to date. So let's talk about the index patient. It's a 67-year-old US born white female. When she was admitted to the long-term care facility, her skin test was 0 millimeters or negative, and she had no prior history of TB. She got transferred from the long-term care facility to the emergency room on July 1st of 2022 with elevated temperature, sorry about that, and change in level of consciousness. She was COVID negative. This patient had no respiratory abnormalities. Hospital chest x-ray was concerning for pneumonia, and so they performed a bronchoscopy. But by the way, this is the 3rd hospitalization of this patient since the beginning of February 2022. Throughout these slides, I'm going to show a series of calendars to show the timeline of events. So on July 1st, our index patient was admitted to the hospital and subsequently had a bronch performed. This reported as PCR positive for Mycobacterium tuberculosis on July 11th, and the very next day, our regional manager made a site visit to the facility to discuss the contact investigation. This is the floor plan that was provided to our regional manager. The facility was 1 level. There were 104 beds with 0 private rooms, and this was an older facility that had many areas with poor ventilation. And during COVID, residents would be cohorted, which meant they would be moved from section to section throughout the facility. I can hear y'all groaning now. Early information related to our contact investigation, we were told that the index patient never left her room and that all meals and therapies were received in her room. She had been in and out of the facility 3 times since March of 2022, which meant that she had different roommates each time. And N95s were used by all employees due to ongoing COVID concerns. So who do we test? The patient had returned home for 11 days in between her long-term care facility stays. So we had 5 household contacts that we identified that needed to be tested. The patient had ongoing therapy throughout her extended long-term care facility stay times. And so there were 9 therapists who were contract providers that needed to be tested. And then 6 roommates that were exposed from the beginning of March 2022 to July 2022. Going back to the July calendar, once a site visit was made, our team was reliant on the facility to pull the information needed in order to test. Based on lessons learned from conducting high-profile contact investigations over the years, we believe in being transparent with our audience, and that means that letters were distributed to all residents, their emergency contacts, and all employees. And the letters stated that an exposure had occurred and that those that needed testing would receive a separate letter providing details on the testing date. We acknowledge in the letter that testing everyone is rarely recommended. However, as the investigation progresses, others may need to be tested. And letters were sent out on that Monday, and testing of the roommates occurred on Thursday. Pay special attention to how long it took for the results of our QuantiFERON TB Gold test to come back. And this was one of the first of many lessons learned in this event. Our lab batch runs our QFTs, and so had we communicated them to them on the front end, they would have prioritized running these a lot sooner. Something doesn't feel right. Over the course of that first week, our staff observed that while employees wore their N95s 100% of the time, only about 50% were worn correctly. Many of them had the mask pulled down below their noses throughout the day. The facility had recently discharged a resident who had no contact to our index case, and admission to the new long-term care facility required an updated TB screening test, and that skin test was positive upon that resident's arrival to the new facility. When we received the results of our QFT results, on the 5 household contacts, all of them were negative. Of the 9 therapists, we had 2 that had moved out of state that we had to coordinate with that state for testing. Of the remaining still in South Carolina, only 1 was positive. Of the 6 roommates, we had 1 that was negative, and that roommate had actually been discharged from the facility and was tested 12 weeks after the date of last exposure. We had 3 new QFT positives and 2 that were indeterminate. So we made an immediate decision to chest X-ray all roommates because of the positive and indeterminate results. And so during a contact investigation in South Carolina, our Department of Public Health usually takes on the cost of all factors associated with testing. So in our state, we use a variety of contracted facilities that we send our patients to for chest X-ray services. So our nearest contracted facility to this long-term care facility was the local hospital. And so we decided to send those residents over there for their chest X-rays. And this is our second lesson learned in this situation because many of these residents were bedbound, which required a lot for coordination of transport. And check-in for chest X-ray services required that they went through the emergency room, which put that vulnerable population at risk for other illnesses. The long-term care facility themselves utilized a mobile chest X-ray unit, which would come on site to perform chest X-rays. And the facility also had contracted lab services, which proved beneficial in obtaining labs on this population that are generally hard to stick. I made a call to leadership. I consulted with our state epidemiologists and our healthcare quality unit, which is our regulatory body, and they are the ones who regulate the long-term care facilities in our state. And I asked them if we could halt any new admissions. I told them that my gut said that something didn't feel right, and that while this was kind of an unprecedented request, we just didn't have a handle on how things were going thus far. And so they reached out to the facility, and the facility voluntarily agreed to halt all new admissions during this time. They were halted for 45 days as we worked through this event, and this proved to be a huge financial windfall for the facility. Going back to our July 2022 calendar, you will see that on the day of the QFT results, we made an immediate decision to halt all new admissions as we worked through the testing, and we received the chest X-ray results the very next day. On the therapist, the chest X-ray result was normal. This was a speech therapist that relied on showing patients her mouth for certain therapies, therefore pulling down her N95. On the roommates, we had 4 negative chest X-rays, and one of the patients that had an indeterminate QFT had an abnormal chest X-ray, so we made a decision to transfer them to the local hospital for an evaluation, and that patient was started on 4-drug therapy for active TB disease. But now we're being told that our index patient actually did have therapy in the facility gym, and so she was leaving her room. So we made a decision to expand the contact investigation. Based on the high rate of positivity in the roommates, we decided to expand beside and across the hall from where our index patient resided during the infectious period. And these were multiple rooms because remember, she was in and out of the facility. We decided to test all facility employees who had direct contact with the index patient based on the inadequate use of N95s. And then we asked the facility to pull a list of anyone who had crossover in the gym when the index patient during therapy. So now we're into August of 2022. We're 3 weeks in from where we were first notified of our index patient. We've started 4-drug therapy on our second case, which was a resident, and now we're expanding our contact investigation. And results from our QFTs were received sooner with this testing event. We tested 29 employees. 3 of those, when they were hired at the long-term care facility, had baseline positive TB test. They were asymptomatic at the time of our screening. And of those 29 employees, we have 16 new positives. Of the 14 residents tested during that time, we had 12 new positives. Some of the items to consider during this time is we decided to use the mobile unit for all the residents with the positive quantiferons. No longer could we consider sending them out to the local hospital. We needed that mobile unit to come on, and of some benefit, some of them have had previous chest X-rays with this mobile unit, so they were able to do comparison. But we sent all the employees with positive QFTs to the hospital, and this was our third lesson learned in this event. So you need to know your client demographics. Many of these employees did not have their own car, and they were reliant on friends and family members to get them back and forth to work. And there were a couple of employees who actually used the local taxi service. And so when you're reliant on others or having to pay for an extra service, getting a chest X-ray was not a priority. And so we had to rapidly deploy our state vehicles to assist the employees in getting their chest X-rays. Now that we have expanded, of the 16 employees with positive QFTs, we had 2 abnormal chest X-rays. And of the 12 residents with positive QFTs, we have 6 abnormal chest X-rays. And I do want to note here that one of the 12 residents with the positive QFT has now passed away under hospice care, but it was unrelated to TB. So we have immediate needs. We were starting to see a high number of latent TB infection, or LTBI, with our testing, but we were on a nationwide shortage of Prifton. So we recognized we were going to need to look at our inventory, and we had many patients across the state being treated for LTBI outside of this investigation that were already on 3-HP regimen. And so we wanted to make sure that they had enough of medication to complete their regimen. And so the 3-HP regimen is a short course treatment for LTBI, and it consists of once weekly isoniazid and Prifton for 12 doses. So I sent out an alert that no new patients could be started on 3-HP and that other regimens should be considered. And I asked our regional pharmacists to pull all inventory and keep it in holding. Due to the nationwide shortage, we were on allocation with Cardinal, and so our state pharmacists had to work with Cardinal to discuss our needs. And this opened the pipeline for that last little bit of medication we needed in order to treat those with LTBI in this event. And we needed to expand the contact investigation. Due to the high rate of positivity, we decided to immediately test all residents and all facility employees. Other things we needed to consider due to the abnormal chest x-rays and having to move the residents out of the facility so that they could get started on treatment and remain in negative pressure until they could come back was negative pressure rooms at the hospital. So our local hospital had 26 negative pressure rooms. And because of COVID, they had 14 additional rooms that could be converted with engineering. We tested 31 employees on August 15th. Of those 31 employees, we have 10 new positives. On August 16th, we tested 55 residents. Of those 55 residents, we have 36 new positives. On August 16th, we also tested the last 25 employees, and we have 6 new positives. I'm going to let this slide sit for a little second just so you can absorb the information. And I'm going to pause for a second in talking. So we're now in August. Due to the overwhelming results, we decided to chest x-ray everyone, regardless of their skin test or blood test result. And as you can see here, in just 4 weeks, we gained 17 additional cases. And keep in mind that the facility was still closed to new admissions at this point, and we decided it was a good decision that we had made. A lot of items to consider at this point in time. Early in the investigation, we kept asking the facility, had anyone been recently diagnosed with pneumonia? And we were told no over and over again. But yet when we were on site, we were hearing other staff talk about, oh, this resident had just been treated for pneumonia, or this person had just come back from the hospital being diagnosed with pneumonia. And these were some of our additional cases. I think in the absence of a complete clinical picture, TB can often be mistaken for pneumonia. We had a pregnant employee who was in her 3rd trimester during our expanded testing, and she had been diagnosed a few weeks prior with pneumonia. She was one of our employee cases, and she was at the stage in her pregnancy where she was being seen weekly by her provider. So this took a lot of coordination with her OB and the hospital where she planned to deliver, and she was infectious at delivery. And the baby was evaluated and was well, but was started on Windoprophy. We had another employee who had been seeing a pulmonologist for nodules on her chest x-ray. This had been going on for months, and she claimed that she had aspirated and that the nodules had formed following the aspiration. Her culture grew Mycobacterium tuberculosis. We made a decision to halt visitation unless the resident was on hospice or palliative care. And this was extremely hard decision to make because this population was so isolated during COVID. And we ultimately decided to use the mobile unit for all chest x-rays, even for employees. And then we had to work with our local hospitals to send residents out for evaluation and initiation of treatment. And the amount of work that this response required us to pull staff from our other regions within our state to assist. Early in our days of testing of the employees, we're in our surveillance activities, we're getting consent to test. We were not considering that the employee was going to have to give that copy of that test result back to their long-term care facility for their employee health record. So we started getting consents to release signed with our consents to test. Because these residents had their own healthcare team within the facility, and these residents trusted their providers, this required us to meet monthly with the facility healthcare team to discuss the residents' record and the care that they were receiving and make recommendations for treatment schedules, both for treatment of LTBI and TB disease. We treated all of the employees with LTBI on Mondays and Tuesdays of the week. So we had a TB nurse that lived 3 hours away that would arrive Sunday night to a hotel there locally. She would medicate the employees on Mondays and Tuesdays. If they didn't come to work, she was out in the community, seeing them in their home. She would drive back Tuesday evening and then see her normal patients in her town. And she did this for 12 weeks to get these employees treated. Our residents had a multitude of comorbidities that complicated treatment, as you can imagine, and we have very antiquated pharmacy systems. Because we were providing the TB medications to the long-term care facility for the residents' usage, we had to take their complex list of daily medications and manually run them through drugs.com to make sure we were looking for drug-to-drug interactions. Throughout the event, we were getting multiple media inquiries, and it was important for us to call this an outbreak when it met the CDC definition of an outbreak, which was 2 or more contacts found to have TB disease. We're also careful to release numbers. This is based off of lessons learned for us from other events. Because numbers and results change so rapidly, it's important to note that the investigation is ongoing and that the numbers are subject to change. And we've already discussed some of the transportation issues by the staff. In all, we tested 96 residents. We had 18 cases of tuberculosis, including our index case. 9 were culture confirmed and 9 were clinical. Note this says early data, and we'll talk about that a little bit more here shortly. Of the residents with LTBI, we had 48. We started 3 on window prophy due to HIV and dialysis. They had baseline negative tests, but they were immunocompromised. So once their follow-up test came back, if they were negative, we stopped the window prophy. There were lots of drug-to-drug interactions, but we did use 3-HP to treat most of them. We tested 115 employees. We had 4 employee cases, 3 that were culture confirmed, and 1 that was clinical. And of the employees for LTBI, we had 44. We started 2 on window prophy due to uncontrolled diabetes, and we did medicate on site at the facility. We had 6 that did not complete treatment for various reasons, and we tried. As we know that your highest risk of developing disease is in the first 2 years following initial infection. Of these 6 that did not complete treatment and not noted in these slides, we had an employee case a year and a half later. So in our resident data, this is our later data, we had a resident that had been discharged from the facility that was now requiring readmission. Readmission requires a new skin test, which is now positive, and the chest X-ray is abnormal with a pleural effusion. This was another case for us. We had another resident that was still in-house. They had a negative baseline and follow-up quantiferon and a normal chest X-ray at baseline, but Christmas 2022, they were hospitalized with a pleural effusion, and this became another case. Now, this is going to be an abrupt stop, but that is the bulk of what we did. So I am going to open it now for questions and discussion.